Hey there, it's Brad. As someone who's passionate about podcasting, I've always thought there should be more support for physicians who want to share their stories and expertise. That's why we're launching Doctor Podcast Network.
We're bringing together a community of physician podcasters with one goal in mind: to provide the tools, connections, and resources you need to grow your show. So whether you've been podcasting for a while or maybe you're just starting, we've designed this network to support you every step of the way, and we're going to help each other rise, not compete.
If this sounds like something you'd benefit from, we'd love for you to join us as we get closer to launch. So you can sign up at drpodcastnetwork.co for early access. Stay tuned for more details in the coming weeks. Really looking forward to what we can create together. Doctor Podcast Network, where doctors podcast.
Doctor Podcast Network, where doctors podcast.
Doctor Podcast Network, where doctors podcast.
Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. We have two amazing guests today. They are the hosts of the Addiction Files podcast. They are both board certified in addiction medicine and family medicine. So first we have Dr. Paula Donnelly Cook, who's been taking care of persons with substance use disorders in many settings, including primary care, street medicine, outpatient, intensive outpatient program, residential, opioid treatment clinic, and inpatient. She's experienced consulting, teaching, and leading, and continues to look for ways to bring harm reduction, lifestyle medicine to people who use drugs or have substance use disorders. And we also have Dr. Darlene Peterson, again, also family and addiction medicine, board certified, specializing also in integrating addiction medicine in a primary care setting. She continues to be heavily involved in policy at both the local and the national level, including her past appointment as a committee member on the National Quality Forum's Opioid Technical Response Panel and a member of the American Academy of Family Physicians Opioid Advisory Committee, and has served on her local hospital controlled substance committee. So Drs. Donnelly, Cook, and Peterson, thank you so much for joining us today on the podcast.
Thank you. It's such a pleasure to join you.
Thank you for having us.
So let's start with what inspired you to start the Addiction Files podcast?
This was really a passion project that we started about 5 years ago. And this came out of both of us teach medical students and residents. And we just found this really lack of addiction medicine training. We were the same in medical school. We just didn't get very much exposure to it. Stigma surrounding addiction medicine we found was really harmful to our patients, not just from the community in general, but also the medical community. So that's where just Paula and I, we trained together in residency, kept in touch. And so we were kind of out on our own, doing our own things. And then we got our board certification in addiction medicine. We realized, you know what, there's this isolation among addiction medicine providers. And then there's also this hesitancy among medical providers to treat patients with addiction disorders. And it comes from this just lack of education, this misinformation. So that's where this kind of came from. We said, okay, how can we get information out there, destigmatize it? And it's such an evolving field. So how do we get rapid access? So that's where the podcast kind of born from, is just really this need to get the information out there. And then it's just such an evolving landscape.
Fantastic. And that's exactly why you both are on the show today, because I think it's really important. It's something that we need to talk about more, destigmatize more, and empower our physicians, really irrespective of what field they're in, because all of us, if we're seeing patients, are going to encounter patients with substance use disorder, whether you're a podiatrist or an otolaryngologist like me. And so thank you both again for taking the time. So first, let's talk about terminology, right? Because words matter, words carry power. And if we're using the right language, it can help to destigmatize, or we can unintentionally stigmatize our patients. And even when we talk to our colleagues, kind of influence how they think about these different problems. So let's start with any preferred terminology that you would like to get out there with regards to substance use disorder and addiction.
Yeah, well, what you said is absolutely correct. The power of language really can govern an interaction, and they've done studies to prove this is true with residents where patients were labeled with certain diagnoses versus others when they actually presented with the same condition and they actually received different care. So basically, we encourage the use of person-first language when it comes to people with substance use disorder, destigmatizing the conditions, just like we do with other chronic conditions. So using person with substance use disorder or a person with alcohol use disorder instead of alcoholic, obviously not using antiquated terms that are more colloquial like junkie or addict. We try to use words that do not connotate someone as making a bad choice, like their urine is dirty or they've relapse. We use words like their urine is tested, positive or negative or expected or unexpected, or they've had a return to use. And there's good articles written on the power of language, just like you said. And so that's a good place to start. And it's difficult in the culture of medicine to make these changes. But as physician and provider leaders, you can really dictate the culture of your team by starting to use those words yourself.
Dr. Peterson, anything else that you would like to add? Anything that we should either make sure we do use or stay away from?
Well, I think Paula brings up really important points, and it's really important in our medical documentation that we avoid that stigmatizing language. And that's sometimes hard because even I've noticed over the years, we have to change the way that we document things, thinking about neutral terms. So when it's a test, just a test, right? It's just a result. This isn't a decision. Like sometimes when a patient, we have an abnormal test. Patients aren't clean or dirty. So we just talk about this, that this test is positive or negative, and just making sure that that's how we're documenting it and that's how we're speaking with the patient, because it also can just think about this as part of the recovery and the healing process instead of trying to perpetuate. And so that part's important. And then I think it's really important with our language with them that we are not trying to further perpetuate that stigmatizing part of, again, that this is a bad choice on their part. The other thing that we use, and this is really common now with just cannabis, is trying to away from the racial of marijuana, because I'll still see a lot of that in charts as I'm reviewing mid-level charts and things like that. So trying to use the medical terminology, either cannabis or THC, rather than marijuana, to try to, again, go with neutral language. So that's a common one too that we'll still see. And those are just things, just thinking about how we're documenting and how we're speaking with our patients.
There's an article called Bad Words talking about the power of language with patients with obesity and bariatric patients. And we had the author of that article, Stephanie Sogg, a few years ago. And that article, that interview still sticks with me because of, they're saying the power of language. So if the listeners want to check that out, I think the episode was called Bad Words, probably released in 2018 or so. It's really interesting how influential the words that you choose can inform your thoughts and the thoughts of whom you're communicating with.
Absolutely.
So what are some misconceptions about addiction or those with addiction that you'd like to dispel?
Oh, where do we start? Because, this is really part of the reason why we started this podcast. But there's first, I think, this age, like just because we have an older patient, this can't be addiction. And also, if something is prescribed to them, then it can't be an addiction. So those are two misconceptions. And also, just because somebody has a dependency on it, then that is addiction. Just because they experience withdrawal, then that is an addiction. So those are two sometimes misconceptions that you'll run into. So
you're saying that if there's no withdrawal, then it's not addiction?
So you'll have somebody who's maybe prescribed opiates for a long period of time, and then you have abrupt discontinuation. And we'll see this in our medical culture. And then it's labeled as this is addiction because they experienced withdrawal. Well, we know that that's just physiological dependence, correct?
Got it.
That's not necessarily addiction, but sometimes we'll have patients that get sent to us that this person has addiction. And so those are some misconceptions that will happen. This is dependence just because they had withdrawal, but that's not necessarily addiction.
So my patients that use too much Afrin have dependence, but not addiction.
Not necessarily. Yeah.
Yeah. Okay. That makes sense. Okay. And anything else that you might hear maybe among physician colleagues that you would want to dispel? Any other misconceptions?
I think we should see amongst physicians, as we do other medical providers and even the public, that addiction is an acute problem and is easily remedied by an acute treatment episode. So, if someone goes to rehab or goes to treatment, then that should be it. They should be better. And we display some sense of surprise when people continue to engage in behaviors that are consistent with substance use disorder. And it is disconcerting and frustrating, especially when people are doing things that obviously are causing them negative consequences, like causing them gastritis or pancreatitis or liver failure, etc. But understanding this misconception that, addiction and substance use is not typically an acute problem. It's a chronic relapsing condition for many people, not everybody, but for many people. And so the perception that they should just turn around on their heel and get better, especially once we tell them to and document in the chart, we've advised that patients stop drinking alcohol and they don't do it, that there's something wrong with the person and they're like incapable or not listening or non-compliant, non-adherent, and a bad patient. Or we feel confused and frustrated with ourselves, and we can transfer some of that onto ourselves. Like, well, what are we doing wrong? We can't manage these patients. These are hard patients. Whereas really it's just the condition is extremely complex. And the perception is that we should change that to a more chronic disease model that just engages long-term care as opposed to acute care.
That makes a lot of sense. So it's not an acute condition, it's a chronic condition and requires continuous management. It's like expecting a dose of insulin is going to cure diabetes, right? No, it's a chronic condition and needs to be thought of that way, where we're not looking for cure so much as we are management. And, as we'll talk about in a bit, harm reduction.
Exactly.
One last thing, if I could just say, this is a common misperception as well, that with these, and formerly known as MAT, when we are using medications like buprenorphine and methadone, those are not substitutes. We'll hear this even among our own colleagues, that you're just substituting one addiction for another. And again, that perpetuates the stigma, and it can be very harmful for patients when they're told by therapists and other medical providers that you're not in recovery because you're still dependent on a medication. And so that's a huge misconception, that somebody is not doing well in their treatment because they're still taking a medication. You bring up a good point there, just like we don't tell a diabetic because they are reliant on insulin that they're not doing well in their treatment. Does that make sense? And
yeah.
They're doing the same thing in addiction.
Yes, absolutely. Although it's a person with diabetes and not a diabetic. Person first language. So what about identifying someone with a substance use disorder, right? Or addiction? For instance, let's start with like a colleague or a trainee. So someone that we're not seeing as a patient, but someone that we know personally or professionally. So they're not walking in with it in their chart or something identifiable in their medical record. So what are some ways that we can identify?
Well, common things are common, and addiction is actually very common, and it's non-discriminatory. So just because we're physicians, it doesn't mean that, unfortunately, that we escape the condition. So that's, I guess, the first thing to recognize is that we're not immune. In fact, we have many risk factors for substance use disorder. There was alarming statistics during COVID, especially around female physicians with alcohol use disorder. A huge number of female physicians met criteria for alcohol use disorder during COVID, I think, due to stress and family duties. But basically the same kinds of things that we look for in patient encounters, and that's just red flag symptoms. So if a colleague or a trainee is calling in frequently, is having these kind of Monday call outs, they seem impaired or look like they have a withdrawal syndrome or a toxidrome, I think it's fair enough to just at least consider that on the differential as well as other things. And then, of course, especially during times of extreme stress, giving people support and considering if they are dipping into substances as a coping mechanism, and maybe even more so if they have a history of psychiatric illness, and making sure that they don't have a substance use disorder, making it a safe space to investigate if they do. So I'd say looking for red flags, having a non-judgmental space where you can ask, although that's very difficult in medicine, obviously, because it's frowned upon and it impairs patient care. And then just realizing that it's common and that many of us are going to have an episode or a recurrent problem with substance use throughout our career. We need to be aware that our colleagues could be right next to us struggling with that.
Yeah, the high frequency of anxiety in physicians, because high achievers and then putting ourselves in a position we're exposed to vicarious trauma all really makes it much more likely that we're going to have anxiety and then a tendency to self-treat on top of access, right? We have more access than other people because of our prescribing abilities. So all of that really makes it more likely that we're going to end up in that boat than the general population.
Absolutely. Like you said, familiarization with the drugs themselves and just self-medicating the stress of the job. I agree.
So that's if it's a friend or a colleague that we're really exposed to. So we're looking for those signs. Oh, and I remember an episode I did a long time ago with Jonathan Winkle, who works in a federally qualified health facility, and he wrote a book about really knowing your patients. He said he had seen a patient with an abscess in his toe, and he drained the abscess, and he did a great job not realizing that the patient was injecting through the toe, and he completely missed the bigger problem. In a situation like that, aside from them having some thrombophlebitis or an abscess in an injection site, any other things that we're going to look for to try and identify it in our patients?
Well, having thorough screenings as your baseline habit is really helpful, no matter what your specialty is, because like you said before, it doesn't matter what your specialty is, you're going to have people with substance use disorder come through your door. So having some kind of a protocol where you ask about alcohol, tobacco, and other substance use in a genuine way where you really are interested in the answer, not just documenting no alcohol, because a lot of times if it's asked a certain way, I think people are willing to tell you what they're using, and that give you a lot of information about folks. And then you can proceed down that kind of tree. If they say, yeah, I have, 3 or 4 drinks a night, well, that might give you information about the reason why they're there anyway. And I think that's something else Darlene and I have talked about frequently in our podcast. We both have received many referrals over the years for patients who I think presented over and over again to their OB or to some other specialty with an unusual presentation that was just very obvious for a substance use disorder, but it was easy to overlook. So, for example, a woman in her 30s with hypertension, and it turns out she's drinking alcohol in excess. So just looking out, remembering that it's a common thing. And like your friend who, incised the abscess, well, what could this be? And could I look into the social story behind this person's physical presentation? And opposite is true, actually doing a physical exam and seeing if there are any, sequelae from someone's substance use that might help us ask, hey, I'm going to ask you more about your social history just so that I could get a good idea of how to take care of you. Do you do these things? And I ask everyone these questions to make it a safe space for them to answer.
Yeah. And I think the safe space is the key there, right? Asking it in a non-judgmental way, making it easy for them to answer, making them feel comfortable connecting with them. So is there anything surprising or underappreciated aspects of addiction medicine that you've learned from your podcast that you'd want the audience to know about?
I mean, one thing I think that we have learned just through our podcast, but also just through treating patients, is just the overwhelming abundance of trauma, particularly with mental health and addiction disorders, that I think is under-recognized. And I think it's important that it's somewhere you have to kind of tread carefully with our patients, but that's developing that trust with them. And that's just something that I think when I first started out, I didn't recognize the level that I was dealing with and how many of our patients just have truly just addiction in general, I think is traumatizing, but so many of them have just suffered just horrible things. And I think you have to be able to be that safe space, what Paula was talking about for them. And that's something that I think is really underappreciated. I think also just there's so much growth that a person can go through as they go through their recovery process. And it's so rewarding just to be able to be there for your patients. And I think we get this all the time from our colleagues of, why would you do addiction medicine? Like, that is probably the question that we get asked a lot, like, be interested in this field, because it's an amazing transformation that you get to go through with your patients, watching them go sometimes literally homeless, living in the gutter, to back to healthy, productive lives, and they're thriving, and they're really just some of the most amazing, sensitive, resilient people that we've ever had the privilege of working with. And so I say that out to all of our trainees and physicians out there listening that are kind of hesitant towards this field, that I'm like, embrace it. These are some of the most amazing people that you'll ever work with, and it's not that other patients in primary care that we work with aren't great, but I think this is an amazing field.
Oh man, not like those hypertensives. They're the worst. Yeah. We hear the same thing from our hospice colleagues, right? Our palliative care colleagues. Like, they love what they do so much. And it makes sense because they know that they're helping the patient so tremendously. But I think the reason that they might ask you that question is because of the social determinants of health that are involved. The things that you can't change, this Herculean task. And yes, you guys are moving, but there are some things that you just can't help them with. And actually, one of the things is, for instance, you have a patient who's just not ready to address their addiction, right? They're not there. Like, I've spoken to patients about smoking and they're like, doc, I just love it. And you know what? It's the favorite part of my day. And I'm like, okay, I get that. We continue the conversation, but how do you handle it when they're not ready to address their addiction?
Well, that's our every day, all day, because if people were ready to handle it, they'd be out of a job. So it's a great question. And I think this is where motivational interviewing comes in, and being pretty skilled at that, which I think most of us in medicine are familiar with. But practicing those skills can be really helpful, and learning how to roll with resistance and really trying to get people to engage change talk. So even if they're not ready, you can just plant seeds or help them plant their own seeds of why in the future they may want to change, even if it's not now. And also being the kind of space physically and emotionally for patients so that if they ever decided to make a change, you or someone like you in another clinic, town, hospital system would be the person they'd come back to, knowing that you got their back to help them. The other therapeutic modality that we found very helpful is harm reduction therapy. So I think we're mostly familiar now with harm reduction, but there's a therapeutic model. Harm reduction therapy is a technique that has good evidence to back it up. Actually, the University of Washington is spearheading a lot of studies about this, but you really just work with people on their goals. So even though you want them to quit smoking, and of course, it's in their best interest, they may just really need to get a job. So you're like, okay, what do we need to do that? How can we get you breathing well enough to get you to go to work, et cetera? And you use just basically working with them only on their goals, even though they seem so far removed from your goals as a practitioner. I think that's been really helpful for me. And I had to really change my mindset away from this medicine mindset of, well, I'm going to advise you. And we do still do that. Like, I'm going to advise you to do these things, but also, what do you want to work on and how can we work with you on it? Now, honestly, I don't think it's we're really good at, because we don't get a lot of training in it as physicians. Some of us get zero training. I think Darlene and I and addiction psychiatrists, and obviously psychiatrists, get training in motivational interviewing, but the rest of us don't. And hardly any of us get training in harm reduction therapy. So we have to have some grace with ourselves.
On motivational interviewing, if you want to check it out, around the time when the COVID vaccines were rolling out, we were using motivational interviewing to try to convince people to get that. So y'all can check out that episode. But I understand what you're saying. It's relationship building with the patient so that they might not be ready to quit smoking today, but you're building that relationship, and you can be like dominoes, right? You're just knocking down the first domino, and that last domino, the smoking cessation, but it's what starts the process. So, it works from a couple different fronts. And yeah, it looks a little far from the ultimate goal, but it makes sense. So for those of us who prescribe opioids from time to time, like I do it really only in my post-tonsillectomy patients, because that is adult tonsillectomy patients, because that is a brutal pain. And then rarely I'll have a patient who's in such severe pain, or maybe they can't take NSAIDs for whatever they have going on, that I will prescribe a very short course, very limited supply. Now, I was brought up in the age of, you're not listening to your patients, and pain is the fifth vital sign. And so, we were encouraged to overprescribe because we're not empathetic to their problem. So what would you all want our listeners to know about prescribing opioids for acute pain?
Well, I mean, from our standpoint, first listen to your patients. We have many patients who are in recovery and know that they have an issue with opiates, and then they go and they have a surgery and they tell the surgeon, hey, what can I do for my pain besides opiates? They're scared. They don't want to suffer and be in pain, and no human being does. I mean, and we're not monsters either. We don't want patients to suffer, but there's always alternatives. If we have a patient who's going to have a surgery who's on buprenorphine or methadone, always consult with their addiction specialist. Always. I can't believe how we don't always have professional courtesy within our own profession, and we don't always reach out. So reach out to their addiction specialist and work with, if you've got somebody who is on a medication like that, work with them, even as a surgeon, because we will adjust their medication, and we can do this almost always to help them avoid opiates. So talk to them about their goals. For someone who's not in recovery and that you don't know that there's an issue, the one thing that we see is many of our patients who come to us who started with iatrogenic addiction. And I think that's really where you're going. How do we avoid this problem in the first place? How do we know who's going to be the vulnerable brain, right? Because some patients will go, I was given one pill and it was the best thing I ever had. But a lot of these, you go back and this person had mood disorders and trauma. And so you could have kind of seen that, but how are you going to assess that in a 10-minute pre-op visit? That's almost impossible, right? What happened is this person, they have this extended pain, or they had complications, and they just call in and say, I'm still having this terrible pain. I would strongly advise, see the person in the office. And if this person is having an issue and beyond what you would expect as normal post-surgical pain, they need to be evaluated. They need a face-to-face evaluation, and you need to determine, is this normal post-op kind of pain? Or do we maybe have something else going on here? Because so many patients, it could have been maybe aborted at that point. If someone maybe would have just had a conversation that, hey, I think you're in trouble here and we need to do something. And some people were already down that road, and it could have, so that's one piece of advice when we have just in those like acute pain situations. And so starting from the beginning, just giving patients an option that could be at risk, and then doing this close follow-up, which takes more time. It's easier to just have your nurse call in rather than have them come back in.
Well, time flew by. We're already at over 30 minutes. I really appreciate both of your time, Dr. Darlene Peterson and Dr. Paula Cook. The Addiction Files, find it everywhere you find your podcasts if you want to take a deeper dive and learn more about it. So thank you both for your time and all you do for our colleagues and your patients.
Thank you for having us.
Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means you either fell asleep or you really liked the episode. So please share it, or like it, or comment on a social media post, or write us a 5-star review. Something. It would really help me out. And maybe what you learned from this episode can help someone else too. The views expressed in this episode are those of the interviewer and interviewee, and don't represent the views of their employer or even their significant other. Even though the magic of podcasting make it sound like I'm talking directly to you. This is not a doctor-patient relationship, and this is not medical advice, or financial advice, or really any advice. Thank us again for listening to The Physician's Guide to Doctoring.